oral progesterone can actually get to the brain very nicely at night. So what does it mean when you have a high mean platelet volume? Does that mean your platelets are bad? So PPC has some really good data for gastric integrity. So if I look at things that almost everybody needs to support cellular health, D3 with K2, because really at the root of all those other dysfunctions, it's immune dysregulation.
Welcome to our Q&A highlights. Q&A sessions are recorded every month, and our enhanced members get an exclusive opportunity to ask questions from one of cellular medicine's brightest minds, Dr. Elizabeth Yurth. Get a chance to ask your questions by becoming our enhanced member at bli.academy/memberships. You also get access to our content library full of tips, articles, videos, lectures, previous live Q&A sessions, and more.
All right, Andrew from Florida, what are your favorite supplements and why? So this is a really hard question, Andrew, and I get asked it so much because honestly, I think supplements are very individual. I really think you should use your supplements very sensibly because of what your labs show or because of disease states that you're fighting, right? So my supplement regimen may be very different than yours. There are some patients who need very few supplements, right? But if I look at things, and this is what I'm speaking to, when I look at using supplements, I really look at things that are trying to balance. Like I'm not going to throw a bunch of NR and NMN into the show because that's going to disrupt my cell balance. I want things that are homeostatic, that are not just throwing a whole bunch that's going to disturb different pathways in my cell. I want to support that. So if I look at things that almost everybody needs to support cellular health, D3 with K2, two work synergistically. So you really want to take them together. Ideally anywhere from 5 to 10,000 IUs. Most people are low. And as we talked about, there's a lot of dysfunction that goes along with low vitamin D, including dying of viruses. We knew that the COVID people who had low vitamin D, very often those are the people who went on to pass away. So magnesium, that mineral supports over 300 different enzymatic reactions in the body, from energy production to muscle function to reducing inflammation. If I look at, omega-3s, we'll talk a little bit about omega-3s because I don't know that everybody needs high dose omega-3s, but I think that if you use omega-3s appropriately, not massive doses necessarily, combined with baby aspirin, because remember, baby aspirin is what modulates what's called the aspirin-mediated SPM or specialized pro-resolving mediator pathway. So if you take the omegas with some baby aspirin, they don't have to be at the same time, then we actually form the omegas into what are called pro-resolving mediators, resolvins, defensins. These are all things that are going to help us fight cancer, fight diseases. So I like the use of omega-3s, but I like it combined with having a baby aspirin on board to help them go down these very appropriate pathways. And I think that that's one of the things that's going to be, when you look at omegas controversies, some of it is what's happening to the omegas. The other thing that can happen with omegas is they become oxidized. So I think if you're going to take omegas, taking taurine and taking a baby aspirin. Taurine is an amino acid that really aids in cardiovascular health, mostly because it's reducing oxidative stress, reducing oxidized LDLs, reducing oxidation of your fats. So I really like a couple of grams of taurine in that mix too. I think spermidine has been pretty proven as a very amazing polyamine to support longevity. I think everybody needs creatine, especially if you're... What is the most important thing to address when you're looking for longevity? That's an interesting question. When I look at what is the one thing, if I had to focus on one place that I was going to change to really promote longevity, it would be the immune system. Because really at the root of all those other dysfunctions, it's immune dysregulation. So think about, so macrophages are these white blood cells, and they play a really critical role. So when the immune system's healthy, they swallow up these dead or dying cells, they remove cellular debris, they are on the lookout for pathogens and other foreign invaders. And so they're basically a sentry to the immune system, right? And when they become dysfunctional, so we start to lose some of this function, or they start to get overwhelmed by all the things that we are exposed to, like viruses and toxins and molds and things like that, then they can't do their job in surveillance against things like cancer. So I think we always think about the immune system and stopping infections, and we don't think about it for other things, right? If we look at the top causes of death, it's cancer, it's heart disease, and then it's infections. So it's in the top 5 causes of death. And so we think, okay, well, the immune system is the big thing for infections, but how about it's actually the big thing for cancer and heart disease as well? The use of melatonin is hotly debated in my world. And I've been to conference after conference where doctors have argued this out. Melatonin's good. No, you're suppressing your own production. It's bad. And I think that number one, don't use it in kids. I think you can disrupt things when you use melatonin in kids. I don't think kids should be taking melatonin. In general, they have good, robust pineal glands. They should make enough melatonin. If they're not, you need to get their sleep in order. You need to do other things to affect their melatonin, not just throw melatonin in. So I see more and more parents giving kids melatonin. Probably not a good idea. But if you look at adults, right? Well, why do we produce less melatonin? Well, a little bit is like, why do I produce less estrogen and testosterone and progesterone? Well, my ovaries just aren't doing the job anymore. What we know is the pineal gland in our brain, which is it's our regulator of sleep and light dark. It just starts to calcify as we get older. And we do a lot in our practice try and help that from happening, but it will get calcified with time. And so I definitely will be producing less melatonin as I age. And I won't say definitely, but very likely will be producing less melatonin as I age. So, a great study just came out in molecular psychiatry, actually August 11th, so just about a month ago now. And it really showed, that age-related calcification of the pineal gland was very linked to these low melatonin levels, and that in general, higher melatonin levels were equated to better health, better cognitive function, less likelihood of developing dementia. And so I think that there is cases where you want to do more than microdosing. We measure melatonin levels, so we kind of, we'll look on it in 24-hour urine studies, and we'll sort of see what melatonin levels look like. But in general, if you feel better on the melatonin, probably it's not doing you much harm. I do like high doses in some of my patients, particularly my cancer patients, my osteoarthritis patients, my cognitive decline patients. So I will use getting into the higher doses, and you would consider sort of a regular dose like 3 milligrams or 5 milligrams, but going up into the 10 to 20 milligrams in those patients if they tolerate it. Now, I do not tolerate melatonin. I do horribly with it. It makes me very groggy. So I think that it speaks a lot to how you feel on melatonin. If you feel better, probably it's a good thing. But in general, higher levels probably are better. And I'm in disagreement with a lot of the people who say, well, you're suppressing your own production. It's a little bit like saying, okay, when you take testosterone as a male, you suppress your own production. Yes, but your own production is just declining. So I will caveat here, there is a lot of disagreement in my field on this, but I'm an advocate of melatonin and of higher doses, particularly in certain people who have disease states that I know will be beneficial. What do you think is the best way or form to take progesterone for postmenopausal women? So in general, I like oral progesterone taken before bed. And that's because oral progesterone can cross the blood-brain barrier. So at night, our blood-brain barrier opens, and that's how we have this lymphatic drainage. We clean out our brain. And so oral progesterone can actually get to the brain very nicely at night and have a very anti-anxiety effect, a very anti-inflammatory effect. So you'll see women sleep better, and men. Women and men sleep better, have less brain inflammation, improved cognitive function. Whereas transdermal progesterone does not do that. It will not cross the blood-brain barrier in that same fashion. So when I will add in transdermal is that some people, when they take oral progesterone, you just can't get super high systemic levels in them. They're rapidly metabolizing it, so they just don't get these high levels that are protective enough for the breast and uterine tissue. So in those people, I may add 100 milligrams or so of transdermal progesterone along to try and raise the serum levels a bit. So if I feel like, wow, they're sleeping well, everything looks good, so I'm getting enough to the brain, but my systemic levels when I test them are not great. So some of those people are rapid metabolizers. Doing the transdermal that's going to stay in the system a little longer might add some protective benefits. We actually look at things like RDW, mean cell volume, mean platelet volume in our longevity world, because they are markers of the bone marrow failing, the bone marrow not doing as well. Okay. And if you think about, so platelets are these tiny fragments, sort of cell fragments that are produced from what are called megakaryocytes in the bone marrow. And then they bud off and they get spit out into the bloodstream. And they live for a very short time in the bloodstream, 8 to 10 days, and then they're destroyed. Most of them are destroyed. So most of those platelets are stored in the spleen. So if you had a splenectomy, that can be an issue with platelet volume. So, and the main function, obviously, for those of you, and I think most people know, platelets is to avoid bleeding. They also contribute a lot to inflammation. They can defend against microbes. They can release growth factors that assist in wound healing and help form new blood vessels. That's why we do platelet-rich plasma injections, right? So what does it mean when you have a high mean platelet volume? Does that mean your platelets are bad? So if you look, research suggests that larger platelets are going to be more likely to form blood clots, that they're damaged platelets. In general, our healthy, good platelets being spit out from the bone marrow are small. The same thing's true about our red blood cells or our white blood cells. They're not huge cells. So as the mean platelet volume or the mean cell volume goes up, usually that would suggest to us that there is something maybe not going right with our system. There's more inflammation, or the bone marrow is not functioning as it should. Big study out of Norway just looking at mean platelet volume, and people who had a mean platelet volume less than, I think it was 9.5 or 10, had a much higher risk of clots followed over a 10-year period. So we know that it's probably not a healthy thing to have that. It is one of the dichotomies about the GLP-1 agonists is they do tend to do a couple of things. Number one, they do tend to raise heart rate, and that's well established. And they do tend in many people to actually lower HRV, neither of which would seem to be a good thing, right? But when you look at all the studies, and when I did literature search, it's about 464 studies that included almost 80,000 patients who were taking GLP-1 agonists, 41,000 GLP-1 agonists, 41,000 controls. And when they were followed up from about 52 to 208 weeks, so for quite some time, GLP-1 agonist patients had much lower risk of all-cause mortality, significant. And reduced of cardiovascular mortality was marked. So even though we see these changes in heart rate and HRV, it does not appear to speak to an alteration in cardiac function that has any sort of health detriments. So BPC has some really good data for gastric integrity. And in mice, you could completely heal ulcers using just BPC. So it's very, very protective to not just the lower GI tract, but the upper GI tract. And it also, if somebody's a drinker or they're taking a lot of NSAIDs, it protected the GI tract from damage. So if you put somebody on, an anti-inflammatory drug where you're likely going to cause gastric damage, you can protect that by putting them on BPC along with it. And it's just super anti-inflammatory. It heals the gastric endothelium, and it helps promote better digestion starting in the upper GI tract. So I love BPC and can't sort of speak highly enough of that in these cases, especially in your ulcer patients, but any of your GI patients who have reflux, things like that, BPC can be so beneficial. The other thing, and people don't think about this, but the other thing that's super helpful for the upper GI tract is Cmax. And we always think about Cmax for the brain, right? But because it's a nootropic and neuroprotective, use it as a nasal spray. But there's a great study, actually human study, treating ulcers in patients with Cmax nasal spray. I don't do supportive oligonucleotide therapy or SOT therapy. It's also known as antisense oligonucleotide therapy for the kind of more, if you get to the cancer world, lots of it's called antisense therapy. And I don't do it, but do I believe it has benefits? Yes. Basically, for those of you who don't know what it is, what you do is you take somebody's own blood. So if I have an infection, like Lyme disease, for instance, I could take your own blood, and that's going to be containing some circulating Lyme bacteria or other pathogens. And then I send that blood sample to a specialized laboratory. And that specialized laboratory actually develops the SOT therapy, which is basically modified RNA or DNA molecules that are going to target specific genes in those pathogens, or in the case of cancer, in a cancer cell. So basically, you collect the blood with these cells or these pathogens, you send it off to a lab who develops an sort of DNA or modified RNA therapy to target those cells and kill them. And it certainly appears to be safe. So overall, I think you want to be done in a facility that's very used to it because there can't be reactions.